Oh, sorry. Should I go ahead, Stephanie?
Kristen, why don't you just give me just a second to do a few housekeeping items, and then Bill will do a few words of introduction, and then we'll turn to you if that works for you.
That's perfect. Thank you.
Great. Okay, thanks, Kristen. So just a few quick housekeeping items. All participants are in listen-only mode, so please use the chat function on the left of your screen for questions. In addition, this call is being recorded, and both the recording and the presentation slides will be available after the webinar as well. And with that, I'm going to turn it over to NCSD's Executive Director, Bill Smith, to do a few words of welcome.
Good morning, everyone, and thank you, Stephanie. Let me thank Stephanie and my great team at NCSD for putting together the webinar today. I'm thrilled with the turnout we have this morning, and I think you're going to learn a lot from our great colleagues at Northeastern University, headed by Dr. John Auerbach and Kristen Gold, who's joining us today. Golden, sorry. I'm really thrilled that we were able to pull together this webinar today. NCSD was part of a project spearheaded by our friends at Northeastern that involved our partners at ASTO, the Association of State and Territorial Health Officials, NACHO, the National Association of City and County Health Officials, and the National Association of Community Health Centers, where we were really looking at the types and levels of integration related to STD safety net services and service delivery with opportunities and challenges presented by the Affordable Care Act and the empowerment of a whole array of providers of services, including primary care physicians. And what you'll hear today is some very important work that we hope advances the field and our understanding, and how regardless of what setting we're working in, our job, particularly in STDs, is to make sure that we're doing good STD prevention and control, and that safety net services are available for the patients and populations that we care about and know who are in need, regardless of who is providing them. So with that, let me again thank John and his team, and I hope you all enjoy this webinar this morning. And again, as Stephanie said, all of the materials will be available on the website, and we will send it out to registrants later. Thanks so much, and back to you, Stephanie.
Great, thank you, Bill. So now I'm going to turn it over to John and Kristen to start our content.
Thank you. Let me try that again. So thank you to everyone for joining us today. This is Kristen Golden, and I'm going to begin the presentation to give a little bit of background on the project, and John will continue with the findings. I was the project manager on this project, and I work at Northeastern University in the Institute on Urban Health Research and Practice. Next slide, please. So this project, is there one before this?
That was the next one John sent me.
Okay. We began this project about a year ago. It occurred in the summer and fall of 2013. And the purpose of our research project was to understand what the efforts were currently to integrate public health in terms of STD services and functions, and how to integrate those with primary care. We set out to understand what the current status of that integration was, what the challenges and opportunities were, and identify some successes and lessons learned from the initiatives that were currently going on. We wanted to do this in order to determine what would help future efforts, and we wanted to help develop some resources to assist this work. Part of our methodology was a series of interviews that we conducted in the summer of 2013. We identified a variety of different health directors, health commissioners, primary care association leaders, and community health centers to inform our work. We identified 12 different areas across the country that represented a diversity of geography, demography, density of population, and whether or not the state or the city was a Medicaid expansion state. In addition to the interviews, we conducted an extensive literature review to look at best practices going on across the country. Following this process and some reports that we developed, we held a meeting where we convened all of the leaders from these areas to come together to discuss the issue in further detail. Next slide, please. What we found was that when talking to public health leaders across the country, public health was very likely to offer some limited primary prevention services for STD. Almost everyone did some sort of epidemiology and disease intervention services. There was some response for outbreaks, and many, many public health departments provided lab services and made sure that people had access to services. There were many clinics across the country that were in a variety of different models. But because many of the public health departments were focused so much on direct care and lab services, the focus on primary prevention was not as strong as many wished it could be. Next slide, please. In the areas where there were public health funded clinical services, they were often not part of a comprehensive primary care site. However, they were clustered with other typical public health services such as HIV, hepatitis, tuberculosis. Sometimes they were co-located with WIC offices, and very often they included some measure of family planning services. We looked a lot at billing and reimbursement and heard a lot about that issue, as you will hear later in this presentation. Because of the administrative burden and the infrastructure required, billing was often the exception, not the rule. And public health departments were very eager to learn more about how to incorporate billing into their routine services. Next slide, please. When we looked at how the intersection between primary care and public health worked, there was some limited collaboration and communication between the two services. Looking at some areas, there was some where there was a good division of labor. The public health department would look at epidemiology and do the DIS to assist the primary care, and primary care would often deliver most of the treatment for STD services. In some areas of the country, public health departments also run community health centers or the federally qualified health centers in that region. So those had a very good collaborative effort going on between their primary care and their public health system. And as I said earlier, in many cases, public health ran multi-service clinical sites that were standalone public health clinics with a variety of different public health services, including STD services. In a lot of different areas, there was some discussion between public health and primary care about how to share the responsibility of STD clinical services. But they were limited, and they were often standalone discussions or small pilots to help test the idea. Next slide, please. But when we look at how chlamydia screening is done and where it is done, it is clear that they are very often done in the private physician's office, especially for women, where almost 40% of women are diagnosed in a private physician's office, compared to less than 10% in the STD clinics or the family planning clinics. So as we looked at how to, what the need was to integrate, it became clear that in order to have a better integrated system, we needed to bring in the health centers and the primary care physicians to begin the discussion about integration. Next slide, please. Now I would like to introduce John Auerbach, who is the director of the Institute on Urban Health Research and Practice at Northeastern University. And John was previously the commissioner for the Massachusetts Department of Public Health for 6 years, and he was the executive director of the Boston Public Health Commission before that. John.
Thank you very much, Kristen, and thanks to NCSD and to CDC and our other partners. And we're very pleased to have the opportunity to share these results with you. As Kristen mentioned, the findings indicated that there was great unevenness across the country with regard to the connections between publicly funded STD clinics and services and the primary care system. What we attempted to do through our study was then to understand what were some of the challenges that public health programs faced in developing stronger connections with the primary care providers for integrated care, and what were some of the opportunities as well. Next. So I'm going to share with you the main opportunities and challenges that we were able to determine. The first has to do with the conditions that are created by the Affordable Care Act. This actually might say more broadly than the Affordable Care Act, the efforts around the country relevant to health care reform. While the Affordable Care Act is a federal act, it's being implemented unevenly around the country, but in virtually every state there are health care reform activities where there is discussion about how to expand insurance options, sometimes consistent with the ACA and sometimes homegrown efforts. What's clear, though, is that the conditions are changing within the country and are likely to continue to change. In some states, they've changed quickly with regard to insurance access, and in other states, not as quickly. Next, please. For the states that have been Medicaid expansion states, there have already been relatively large segments of the uninsured who have been given new opportunities to become enrolled in Medicaid and other subsidized programs for low-income people. So we think that it is likely that we will see the most dramatic changes with regard to the ways that publicly funded STD services operate in those states because of the larger number of low-income residents, including residents who may have previously used STD clinics, who now will have insurance, and many of whom for the first time will be seeking primary care on a regular basis. Next, please. For those states where there hasn't been Medicaid expansion, there is, however, still an impact of the Affordable Care Act because subsidized health insurance programs are available through the federal insurance exchange, and that is resulting in many people having access to insurance who wouldn't have had it before. In addition, another aspect of the ACA is the ability of young people to stay on their family's insurance until they're 26. And so for those individuals as well, new insurance opportunities exist now, and in an increasing number of individuals are having their care followed by primary care providers. So here, too, there may be an impact on the STD clinics. Next. One of the findings that we observed was that the public health leaders at the local level and the state level were not always aware of the specifics with regard to the impact of the ACA and healthcare reform. A number of people that we talked to suspected it was going to have an impact, thought that more people would have insurance, but really weren't sure about how many people were going to be covered in what period of time. In addition to that, there was uncertainty that was identified with regard to whether traditional patients who had previously been uninsured and now might be getting insured would decide where they would get their care. And a number of the people we interviewed believed that the traditional STD patients who were uninsured would stay with the STD clinics if given the option, even if they became the patients of primary care medical homes that included STD services. So there was a good deal of uncertainty about what to expect. The conclusion in this area was that there was a need for active seeking of information on the part of local and state public health officials to monitor what was happening in terms of insurance coverage and monitor what was happening in terms of patients who were enrolling in primary care sites, most particularly the federally qualified community health centers, so that there could be a greater ability to anticipate the impact over time on STD clinics and the potential for operating in a different way, either because volume was changing or because there were stronger connections between the publicly funded STD clinics and primary care sites. Next. A second major challenge that was identified was that there was the impact of budget cuts and other resource obstacles that made it challenging for health departments to proactively have a handle on what kind of STD services were necessary in the changing environment. Next slide, please. A number of the states and locals said that they were still feeling the impact of cuts that had taken place during the recession. Sometimes services hadn't been restored, and so they already felt the impact of reduced STD budgets, more limited hours for services, and that this was a problem. On top of that, a number of states and locals shared with us that regardless of whether their state was a Medicaid expansion state, there were often discussions in the legislature about whether it was possible to make additional cuts in public health as a result of expanded insurance opportunities. And there was fearfulness that legislators would cut STD funding first with the assumption that it was less necessary as insurance expanded, rather than monitor whether in fact that was the case. Next, please. An additional concern with regard to budgets were services that were complementary to the STD publicly funded clinics and sometimes provided similar services. So, for example, cuts in some areas to Title X programs or to family planning services were resulting in reductions in the availability of STD services. Some of the sites that we talked to explain that they actually had a demographic division of labor where men were triaged to the STD clinics and women seeking STD services were often triaged to the family planning facilities, sometimes within the same clinic. Under those circumstances, obviously, if there were cuts to family planning, that would have an impact on where those women would receive their STD services, and it would be necessary to adjust plans in order to provide expanded care elsewhere. Next, please. So the reason that this challenge is significant is fairly obvious. Budget cuts may reduce services and flexibility. And in addition to that, many of the participants in our study relayed that there was limited capacity for their health departments to handle many different problems at the same time. And if, in fact, the department was focused on handling a cutback, maybe with layoffs, it was difficult simultaneously to be thinking about were there new opportunities to establish linkages with primary care sites, simply because people may not have had time to handle both the headaches and administrative steps necessary to do cutbacks and also embrace the reaching out and the setting up of meetings and the consideration of new referral mechanisms that might be opportunities with increased integration of services. Next, please. A third challenge was that the availability of primary care across the country was notably uneven. There were many parts of the country where primary care medical sites, and in particular here I'm talking about community health centers or federally qualified community health centers, where those existed in a number of different locations. Most commonly, they were found in urban areas, but also in rural areas. However, there were wide areas of the country where there was not obvious sites for the provision of primary care to the populations who had traditionally been served by STD clinics. We heard this loud and clear from the states and counties where there were large rural areas and where it was not uncommon for clients to have to drive long distances to find a primary care provider. In addition to that, we heard that there were those locations where primary care providers existed. There might be a group practice in a particular community, but those practices were not always accepting patients, or they were not always accepting patients with a certain kind of insurance, in some instances Medicaid, and therefore the possibility of access to primary care couldn't really be taken advantage of even when people for the first time had an insurance card. So a good deal of investigation, community by community, was necessary to determine when it was realistic to assume that patients could be seen on a regular basis by nearby primary care providers who could reasonably be expected to provide STD services, and where that wasn't possible because of the lack of primary care providers in a certain geographic area. 4. Next, please. Next slide. I'm sorry, this is just an indication of where we don't see the lineup of STD concentration matching exactly where the federally qualified community health centers are. Next, please. And I covered this point, so I'll go to the next slide. A fourth area that we heard of was the continuing stigma and discrimination that exists surrounding STD, as well as the discrimination that certain of the clients who use our STD services have faced when they've tried to seek services in other locations. Next. In interviewing the health officials, we were told that STDs still are stigmatized in many parts of the country and in many communities, so much so that in numerous settings, patients might not seek STD care if they were worried about being observed by a neighbor, a family member, or even their own doctor. We heard of instances where teenagers were reluctant to seek STD services at the primary care providers because they were afraid their parents would find out. And again, we heard about the small-town rural area concerns that you might know someone when you walk into the primary care office. So this was raised as a concern that needed to be addressed. Next. And in addition to that, the STD publicly funded clinics have prided themselves on being locations that are open to all populations and welcoming to those populations, even populations or especially populations that may not have been welcomed or felt comfortable in other settings. And those included men who have sex with men, transgender people, in some parts of the country, people of color or low-income people who feel welcome in the STD clinic but may feel that the local primary care provider might not make them feel welcome. this is not the case in all settings, but what we heard from during our interviews was it was important to investigate this and make a determination where those conditions existed and how to try to best address those. Next slide. And this slide indicates that it's important particularly to think about the continuing stigma and discrimination, because many of the groups who face that discrimination are groups who may be at disproportionate risk of poor health and health conditions, including STDs, and therefore in need of ready access to care. Next, please. Again, this is this summary slide. Next slide, please. A fifth challenge is that, as Kristen mentioned earlier, STD services in many locations are linked to other services. Next, please. States and locals often run clinics that house a number of different publicly funded services, and those services sometimes include immunizations, family planning, and WIC. All of those services in a number of these locations share the infrastructure, the rent, sometimes the staff. Next, please. So it makes it difficult to think about scaling back on the provision of the publicly funded STD clinics without considering whether that could potentially have an impact on the overall operations of the facilities with shared services. There may be opportunities for integration with each of those services, but that needs to be taken into account so that the evolution of the blending of the services is respected, and consideration of STD integration isn't done in isolation. Next, please. And then a final area that was raised as a challenge for consideration was the importance of ensuring that the clinical expertise that was necessary to treat patients was available at primary care sites. Next, please. While many primary care sites have the expertise to treat STDs, and particularly routine STDs, there was concern that some primary care practices were not as expert in treating STDs. Some primary care practice, in fact, may not have had experience in actually taking a sexual history. Here, again, let me clarify that I will distinguish between services that are offered at federally qualified community health centers, where there's a much greater likelihood of having expert clinical staff who are familiar with STD and STD treatment and working in collaboration with the public health department. And on the other hand, small private practices that may traditionally not have provided those services, but might now be seeing patients coming in who are newly insured who are in need of them. Next. In discussion with the STD and other public health officials, we identified that there was a need to pay attention to skill building for clinicians in a variety of ways. One way was looking at where training occurred. This would be both medical school and nursing school, and working with training sites to support the training modules that would prepare them to take sexual histories and treat patients with STDs. And that in addition, clinical skills were necessary for those who are already in practice but unfamiliar with STD treatment. Finally, there was a general agreement on the part of the people we spoke to that it might be necessary to always retain the STD clinical expertise in the public health arena, so that as greater STD service delivery occurred in the primary care settings, there was always the possibility of conferring with the STD expertise at the state or the local level. Next. As Kristen mentioned, following our surveys, each of the teams sent 4 to 5 members to CDC for a 2-day meeting, and we did a good deal of planning and discussion about the best ways to consider moving ahead with integration. After that meeting, we surveyed the participants and asked if there were particular subject matter that would be helpful for them to learn more about as they continued to investigate the feasibility of integrating STD services with primary care providers. That survey resulted in identifying 2 different areas where there was requests for information, and we did webinars in each of these areas, which are available on the ASTHO website. They were recorded along with their slides, and if you're interested in learning more about either of these subjects, they are available on the ASTHO website. But I'll very briefly review what the content of those were. Next, please. The first was the issue of the electronic health records and the possibility of developing systems of communication that would make it easier for public health departments to communicate with primary care sites about the care and treatment of patients with STDs. So that, for instance, if a primary care site was caring for a patient population, but it was important to know the people who might have been exposed and to communicate and share information about who had been talked to, who had been treated, there was a clear mechanism for doing that that was less complicated than faxing information back and forth. For that webinar, we were joined by Jim Daniels from the National Office that's working on health information technology and public health. And he shared with us that there is a good deal of work that's being done at the national level to create the kind of systems state by state where such communication could occur. Next. And he gave an example of where an electronic medical system had been developed in New York City that allowed for accurate and quick communication between primary care sites and public health then and primary care sites to ensure that timely and high-quality care was provided regardless of the location where the STD was treated. Next. A second area of concern that was raised that required greater attention had to do with the challenges that are faced by insurance policies' explanation of benefits approach. The explanation of benefits is when the services that were delivered to anyone covered by insurance results in a letter being sent to the holder of the insurance policy with the information about the services that were provided and to whom. And what we heard from a number of the local and state STD officials was that there was fear that if STD patients, teenagers in particular, or people who are concerned about domestic violence, sought care in a primary care setting, that would result in a letter going to the holder of the insurance in a way that might create difficulties for the patient, and that if they feared that, they might not seek care. That STD clinics were a way of avoiding that because they didn't, in most cases, generate an explanation of benefits. So we discussed that on our webinar with national experts who were monitoring that in some states there was, in fact, efforts to change the laws and make the laws allow for withholding explanation of benefits when the information was sensitive. However, the assessment was that that was probably, those laws were not likely to be passed in most states. And so there were some additional thoughts about how, about ways of recommending care that might be, that might take that into account. One way was to work with the clinicians in a community so that those caring for adolescents routinely performed STD tests, and that parents were notified through their pediatricians that part of a routine examination of an adolescent was testing for an STD, so that if an STD test appeared on an explanation of benefit, it would perhaps raise less eyebrows on the part of the parents. Next. We heard from work that was being done in one location where there was a development of a specialized training program for the local pediatricians, where they were given a checklist. This is an example of one of those checklists that they were being asked to follow on a routine basis with adolescents, regardless of whether they were identified as at high risk for an STD. And part of that was reminding them, as this checklist does, to routinely order a chlamydia test. And then complementing this was educational material that was made available to both the adolescent patient and the parent, that this was part of routine care in those settings. Next. We were left with the encouragement to stay in touch with the work that's being done on a national level to think about explanation of benefit policy, but also to work within our local areas and state areas to educate insurers, providers, and beneficiaries of the importance of being sensitive to this issue and thinking about ways to protect the privacy of individual patients that might seek STD services. Next, please. So, in summary, while moving ahead with attempting to integrate STD services as much as possible in primary care settings, this summarizes the 6 areas where attention is necessary at the local, state, and national level to ensure that we're able to continue to make progress. Next. And I would leave you with this as the last slide. We attempted to understand better what we meant by integration by asking the participants in this study to consider where they were on the spectrum that you see on this slide. On the one end of the spectrum is isolation, and that's where primary care provides clinical services, public health runs free STD clinics, and there's limited or no collaboration that takes place. And on the other end of the spectrum, where we see merger, that's a situation where there would be primary care providers provide most, if not all, of the STD clinical services. Public health provides epidemiology, outbreak control, prevention, and education, and they work together as a team, but with that very clear division of labor. Most of the locations we talked to said that they were somewhere in between, more than halfway towards the merger end of the spectrum, meaning that there was a clear division of labor between primary care and STDs services, where increasingly primary care sites were providing STD services as more and more people gained insurance, but where there was still some provision of publicly funded STD services that was available for those patients who remained uninsured or for the reasons that I've reviewed did not feel comfortable or were not able to seek services in primary care sites. And I think there was a general consensus that as much as possible the participants felt that we should be mindful of the opportunities to move along the spectrum, take advantage of them whenever that was possible, and in the best interest of patients who were increasingly able to take advantage of primary care medical homes that could treat all of their conditions and not simply some. With that, Stephanie, I'll turn things back over to you, and both Kristen and I would be happy to answer any questions.
Great. Thank you, John, and thank you, Kristen. So if you have a question for our presenters, please enter it in the chat function to the left of your screen on your computer. As I said, we have a number of participants in this webinar, so all participants are in listen-only mode, so please use the chat function for your questions. We did get a few questions as you were speaking. One of the questions was a question on challenge number 5. One of the participants wasn't quite clear on what the challenge was regarding the integration of STD service. They seem to infer that the integration of services was not a good idea to increase STD screening. Maybe, John, you could talk a little bit more about that challenge and what the interviews found and why it might be a challenge for STD programs.
This is challenge number 5, did you say?
Yes.
Okay, so the challenge number 5, just to clarify, was referring to the fact that where publicly funded STD services exist in many parts of the country, they're not freestanding STD clinics. They are STD clinics that are housed within multi-service sites, and those sites provide a range of different other publicly funded services. So what I was talking about in particular there was when a local health department is running a bunch of different services in a particular location, the local health department has to consider the impact of fewer services in one arena because that might appear to be isolated to that area of service, but it in fact might have an impact on the other services that are within that location. The most extreme way it would impact it is if the STD services actually moved out of that location and were just completely integrated into primary care sites, then there might be issues raised to who's sharing rent and sharing of staff, that sort of thing. I'm not sure whether whether the question was related to that or whether it was asking more specifically about the integration of STD services within primary care sites. Were you clear about that, Stephanie?
I think the answer you gave did answer the question.
Okay.
Thank you, John.
Okay.
I wanted to ask a question. So obviously, John and Kristen, you guys are not necessarily new to public health, that you guys have been around public health for quite a number of years. Is there anything throughout this project that surprised you in doing this research?
I would say that one thing that surprised me was the diversity of the challenges that people are facing around the country. You know, I've been involved in public health for a long time, but had found that I was making certain assumptions about the access to primary care, or how much progress we had made in overcoming some of the stigma associated with STDs. And what we found was very different answers from different people we spoke to. There were parts of the country where people said, absolutely, we take it for granted. There's access to federally qualified community health centers. We've recently built beautiful ones in our area. People can take advantage of those. And, you know, we've worked a lot on stigma. It's much less of an issue. Other locations said just the opposite, that there were real shortages of available primary care sites, no FQHCs within the area, and in other instances people relayed that, particularly I'd say in some of the smaller towns, that stigma was a major issue and an obstacle that was felt to create real barriers to the access to care.
Great, thanks, John. Kristen, did you have anything you might want to add to what surprised you about this work? I think we may have lost Kristen. So moving on to our next question. We have a question regarding what has happened, and do you know of any through your research what has happened to STD rates in those areas where STD services have been moved entirely out of public health sites and into primary care sites?
So I'm not aware that that's been studied, and I think that is in part because I think it's only in the last year or two that we've begun to see the impact of the expanded insurance options. So there's always a lag in terms of reporting. So I think we're going to see more. We're going to get more of an information on that as in future years. I will share with you our experience in Massachusetts, where we implemented healthcare reform now 7 years ago, and part of what occurred along with healthcare reform was a reduction in the freestanding STD clinics. In those instances, we didn't see a notable change in terms of STDs within the state. We saw the basic trends that we'd seen before, more or less continuing, in some cases going up and in some cases going down. So we weren't able to see a measurable impact.
Great, thank you. I know that we get this question from both members of Congress and coalition partners as well as our members. I just think it's so hard to know this so early and to know what of the forces are leading to increases or decreases in STD rates. So thank you for your feedback on that, John. I think Kristen, I've rejoined us. Kristen, I wanted to give you the opportunity to answer the question about if there's anything that surprised you in this work.
Oh, thanks, Stephanie. I think, not so much a surprise, but I think what we learned in this process, which we maybe didn't highlight so much in this presentation, was the very real and different kinds of perspectives that are shared by community health centers and how they think about integration with public health. And so there were health centers who really felt like these patients were their patients too, and that they felt that they could very well handle STD services and that they were eager to do so, but they did not want to infringe on what was traditionally seen as a public health role. And then there were many who said, oh, we could not handle those patients. We don't have the infrastructure right now, or we would have to really think about that, and there's a lot of work to be done to think about how that could happen in terms of capacity. And it did surprise me the level of communication that had already occurred between public health clinics and federally qualified health centers who were the participants in this project. In some areas of the country, there was great communication, and they were very clear about each other's roles, and in others, not so much. So I think for me, that's where we learned a lot, and where the perspective of the National Association of Community Health Centers and all the different participants from the primary care associations and the community health centers themselves was really helpful. And it was helpful for the public health folks and the primary care side to discuss these issues in person.
Great, thanks, Kristen. I think that your comments go well into a question we received from a participant who said, is it possible to give more concrete examples or specific examples of a division of labor between primary care and public health? Examples of what you see as proposed or primary public health responsibility and what is primary care responsibility?
Yep, I think that's a great question. Here, Stephanie, if it's possible for you to return to the slide that's one of the earlier ones that titled Profile of Public Health Services Provided, it might be helpful. In general, in terms of our discussions, there was a clear consensus that the core public health work on STDs that would not be changed by movement towards integration involved the epidemiological work, the disease intervention specialists, the outbreak response, and to a somewhat lesser degree, the laboratory services. The most attention with regard to integration has focused on the direct provision of care and whether or not the direct services, the STD clinics themselves, should be examined with regard to whether or not those services could be provided in a primary care setting. The caution that I mentioned earlier about laboratory services was because many locations now are looking into whether the publicly funded laboratory services should in fact, whether they're still necessary to perform certain tests that can be performed by private laboratories where insurance will cover the cost of those tests, and whether it makes sense to preserve publicly funded dollars simply for those people who don't have insurance. In other instances, people felt like those laboratories should continue, but that they should just do the billing and retain the funding if it's possible within the public health system. But just to summarize, the location where the most intense interest exists with regard to integration is with the direct delivery of STD services to patients.
Great. I think that underscores some points that I'm always trying to make with elected officials, is that when they think of public health services, they're only thinking of the test and the drawing of the blood and or the culturing. They don't think about all these support services, for lack of a better word, support services that go along with all this, which are the key functions of public health that primary care, as you said, will not necessarily be fulfilling. So thank you
I do think that's important, and I think it's worth highlighting because this is a period of time where decisions are being made at the state, federal, and local levels about funding, including funding for STDs. And if there is this sense that when policymakers are talking about STDs, STD services, they're really only talking about that direct service provision. They may make different decisions about the budget than if they fully understand the range of services that are provided. The second area that I think it came out of our research was important was that with regard to how quickly integration can occur, there isn't a one-size-fits-all formula because of all those obstacles that we've mentioned. If you don't have primary care providers in your area, you just can't do the integration, for example. However, I think that the clear movement among funders and policymakers is towards, whenever possible, move in the direction of integration and providing services to patients in primary care medical homes, patient-centered medical homes, where all their services can be provided in a one-stop shopping location. And so balancing both diversity of conditions in the country with the consistent movement everywhere it's possible to have greater integration of services in primary care for those patients with insurance who are going to primary care providers is part of the challenge.
Great, thank you. Had another question here. Are there model states who have expanded Medicaid, who have successfully partnered with their Medicaid to improve STD care provided by primary care providers?
Is the question there mainly about the partnership with Medicaid?
Yes.
Let's see. I have to say I'm not an expert in the area, in particular about partnership with Medicaid, and whether or not programmatically that has been a connection that's had particular results. I will say that many of the Medicaid programs have the advantage of not sending explanation of benefits. And so what some locations have found is for patients who are eligible for Medicaid, and it's always best that a local health department or a state health department double check this to be the case, but in those instances where Medicaid does not send an explanation of benefits, that's important information for those who are sharing information with patients that are trying to decide about where to go. And in those places where Medicaid does not provide explanation of benefits, it's sometimes useful to be able to point to Medicaid as an insurer who doesn't do that to the other insurers where we're trying to get their attention around the potential dangers of that policy.
Great, thanks, John. As a reminder, if there are additional questions, please enter them in the chat function. I think I've answered all the questions I've received right now. I might give a few minutes to see if there are additional questions that enter in on the chat function. Well, if folks don't have any additional questions, I think I will just take a moment and thank both John and Kristen for joining us this afternoon and providing us with some information about this project. It was very informative. I'm very glad that we could organize this for the NCSD membership. Just as a reminder, today's call was recorded, and both the slides and that webinar recording will be available after this webinar on our website, and I will send out an email to all registrants with the recording and slide information. In addition, I'll also be putting something in the NCSD Weekly, most likely next Friday, if not this Friday, with the recording and a link to the slides. So all of that information will be publicly available to you. So thank you again for all of your time today, and thank you, John and Kristen. Appreciate your time.
Thank you. It's our pleasure.
Thank you.
Thank you.